I am Peggy Kayamian, one of the founders of Beyond Concussion, and we are excited to start our workshop series again this year. We've had it in the past and it's been a while, but we are looking forward to having one every month. And to start with, we have Aaron Parr, who's going to kick off the workshop series. Welcome, Aaron. Can you introduce yourself?
Sure, absolutely. So I'm Aaron Parr. I've been practicing as a physical therapist since 2013. I've lived many different places and have practiced in many different settings. Ultimately, my path has taken me through Arizona, Illinois, uh, Orange County, and now down to here. And I've deviated a little bit from the clinical role that I previously had. Now I'm doing more research, but still very passionate about physical therapy and kind of my area of expertise, which is chronic pain. And at I'm a fourth year PhD candidate in the joint doctoral program in public health at UCSD and SDSU. And my research is primarily in headache after head trauma. So, and persistent headache at that. So, persistent post-traumatic headache. And looking at um, biological correlates of pain-related phenomena. So,
Thank you. We're excited to hear um, and learn from you today.
yeah, we'll jump right into it. I really like open dialogue, so don't hesitate to interrupt, raise your hand, blurt out. None of it will derail our forward progression. It was totally fine. It's better to have this be as interactive as possible, especially 5:30 at night. I know it's later on in the evening, but um, good job being here today, and hopefully you'll take away something that you'll be able to utilize to help a pain experience that you might have now or in the future. Hopefully not in the future, but pain exists and it exists for a good reason. And it is likely that we all will experience pain in the future. So we need to know how to deal with it. The format for today and for other sessions is going to be kind of as follows. We'll have a 30-minute presentation, and then after that, we'll have Q&A, and then maybe a demonstration. Today, I'm going to demonstrate some exercises, so we'll integrate that into the latter part. All right, so we'll get to using exercise to treat chronic pain after concussion or head trauma. Just kind of want to detail some of the objectives of what we're going to be discussing today. One, discussing the prevalence of chronic pain after head trauma, explaining why exercise can help improve chronic pain, providing some exercise guidelines for those of us that want to increase our physical activity and increase exercise, and demonstrate an exercise routine that targets head and neck pain because those are seem to be the most prevalent uh, chronic pain symptoms that are experienced after head trauma. Now, around 25% of the general public experience chronic pain. So if we took a random poll of four individuals in the United States and we asked them whether or not they had chronic pain, and what is chronic pain? Well, that's pain that's been experienced for at least 3 months. So ongoing pain that's been experienced for at least 3 months. One out of that four is going to likely say they have chronic pain. That's a large portion of the general public, right? 25% having at any one point ongoing pain that's been present for at least 3 months. Now, what about if we looked at a subpopulation within that general population? and that subpopulation being individuals who have survived a head injury. What rate of chronic pain would we see in that subgroup? Around 50%. So instead of that one of four, two of four. Around 50% of people who have survived a head injury experience chronic pain. And so the question becomes, why are chronic pain rates 100% higher in people who have sustained a head injury? 100% higher. Why might that be the case? And one reason for that is head injuries can increase the sensitivity of pathways related to the experience of pain. So you can appreciate, a noxious stimulus, in this case, a nail in the hand, is going to trigger a response. It's going to alert the systems across the nervous system that a noxious event is happening at the hand. And it does so for a very good reason, because we use behaviors to help protect ourselves. So that event, that nail, if you will, in this circumstance, causes a signal to travel along pathways ultimately towards the brain where pain can be experienced and behavioral changes occur. Pain is a good thing. We need it for protection, right? After head injury, though, and after many injuries across the body, what you can see is a sensitization of those pathways, an augmentation of how those pathways respond to input. And so the brain and the brain stem and all the other relay points along these pathways all of a sudden start getting flooded with more and more information than they typically do. And so that's what's really interesting. The amount of information that's ultimately sent and reaches areas of the brain important for deciding behavior, that amount of information increases. And this has been looked at in headache after head trauma, in terms of for individuals that have chronic headache after head injury, what their sensitivity to stimuli are. And as a surrogate measure for sensitization along these pathways. And so what we see here is this group right here, which are individuals that have chronic headache after head injury. We can see that they're more sensitive to a pressure stimulus than individuals that have headache but don't have chronic pain and control. So individuals that have not had headache or a prior history of traumatic brain injury. So what this reflects is that when you apply pressure to part of the head, for instance, for these individuals that have headache, they experience pain at a lower pressure threshold than, for instance, individuals who don't have that chronic pain experience. And so it's indicative of an increase in sensitivity along the pathways that transmit information about tissue threats and is important for behavioral responses. And so, what is sensitization? I think it's good to just kind of have a picture to kind of dial in what exactly we're talking about. So, let's imagine that the pathways associated with pain are represented by the smoke detector, okay? The smoke detector's job is not to alert you of every threat, but rather the more concerning threats, right? So, for instance, the smoke detector is not useful if it sounds an alarm every time a candle is lit within a house. However, it is useful if it sounds an alarm every time your house is on fire, right? So before a head injury, presumably it's more likely than not the alarms are operating appropriately. The non-threatening stimuli, the candle that's being lit for the fragrance is not causing, the smoke detector to go off, but a more concerning threat, your table on fire, the house on fire, that is causing a response. Your alarm system is responding proportional to the threat. After head injury, the system changes and you may start having a lot of false alarms. So, for instance, the system may become more likely to interpret non-threatening stimuli, such as a lit candle, as threatening. And so now your brain is alerted for very benign things, for things that shouldn't cause a reaction. You are focused on the events that occur around you for all the wrong reasons because they're just triggering response after response. And some of these changes that occur, we have names for what they look like behaviorally. So allodynia is one of those changes, and that's really where you start to have pain experienced with what are typically non-painful stimuli. So you can imagine if someone stroked a feather across your tissue, under normal circumstances, that feather would be interpreted as a brush. It wouldn't cause you to experience pain. But after a head injury, after an injury episode in different places of the body, all of a sudden that non-painful stimulus can become painful. And what this looks like physiologically, or at least what we think is this is reflected by physiologically, is this event over here. So I just think this is kind of cool to see what we observe in animals. And what we think are the physiologic correlates of allodynia. So, this situation where a non painful experience becomes painful. So, before inflammation, we have this nerve that's in the spinal cord responsive to some stimuli and not responsive to others. And what we see it's not responsive to is this non threatening pressure stimulus. And then after injury, what you see within this nerve is that it becomes responsive to the pressure stimulus. And so we think that's what underlies this allodynia that is observed, kind of an unmasking of these activity patterns so that after injury, non-threatening stimuli all of a sudden have access to these pathways that cause pain to be experienced. Another situation is hyperalgesia, and that's where threatening stimuli, so typically painful stimuli, are interpreted as more painful than they were previously. And what that kind of looks like, or we think is represented by physiologically, is an event where you have a stimulus being active before injury, and then after injury, it becomes more active. So the amount of information that it transmits up to the brain is augmented. And then spontaneous pain, which is pain at rest. Here, physiologically, we think this is reflected by a situation where the nerve typically is silent, um, without any stimulus, but after an injury, it becomes active. And so, a reason for you to then have pain persist at rest. So, the question is, how do we calm the alarm system, right? How do we turn on the water sprinkler to reduce the sensitization that has occurred along these pathways that might be limiting our functional capacity and our ability to accomplish goals that we want to have accomplished? Well, there are ways, strategies where we can use the brain, the brain and the central nervous system's endogenous ability to control the sensitivity or the signals that are transmitted along these pathways. So you can imagine we have a pinprick to the finger, information comes in through the peripheral nerve and then communicates with a nerve in the spinal cord, and that sends information all the way up towards the brain about this threatening stimulus. And we might have a pain experience. What the brain can do is it can respond to that and cause information to be sent the other way. and chemicals such as serotonin and norepinephrine to be released to reduce the likelihood that this pathway transmits information up towards the brain, to reduce the amount of signals the brain receives, ultimately reducing the pain experience or controlling um, the pain experience. And so, what are some of these desensitizing strategies that we can use? Medication, right, being a strategy, exercise, which is what we're going to talk about today, being a strategy, even psychotherapy being a strategy. What I want to highlight, of course, today is exercise, but I also want to make sure that you are aware that the other strategies do have efficacy too. In fact, there was a study that was recently done and published on cognitive behavioral therapy that emphasizes the headache experience in individuals who have persistent headache after head trauma and was found to have very good results on improving headache related disability. So, yes, we're going to talk about exercise, but oftentimes when we're thinking about strategies to reduce the pain experience, a multimodal approach is helpful. In terms of different exercises, aerobic exercise and strength training can be great pathways, avenues towards reducing the sensitivity of these pathways associated with the processing of pain. So, we're going to kind of talk about aerobic exercise and strength training. And as they pertain to a couple different common pain states, headache and neck pain. Headache is the most common chronic pain symptom after concussion. Here are at a measurement at 6 months, the most common persistent post-concussive symptoms, fatigue, concentration problems. These things persist, and closely behind is headache. And so it's important that we realize how impactful headache is and how prevalent it is. So, for those that experience a mild traumatic brain injury, around 50% develop post traumatic headache. So, two of every four individuals that have experienced a traumatic brain injury, around 50% develop headache after head trauma. And around 50% of these individuals will have persistent symptoms at 3 months. So, this equates to, for four individuals that have a mild traumatic brain injury, one of the four will have persistent symptoms at 3 months in the form of headache. And around 35% will not have return to work by 3 months. So it's a return to work limiting factor. It is both prevalent and disabling. In addition, we'll also talk about using exercise to improve chronic neck pain because neck pain oftentimes occurs concurrently with headache. Neck pain triggers headache in about 56% of individuals with persistent post-traumatic headache. So oftentimes it's something that we want to consider when we're thinking about intervening on chronic pain after head trauma. In addition to it being common, it's also debilitating. Neck pain that precedes or accompanies headache episodes is related to lower physical function. Here, lower SF36, which is a bodily pain domain measure, lower SF36 bodily pain domain scores indicate lower physical ability because of bodily pain. So, individuals that have neck pain with their headache have lower physical ability because of that pain than individuals who just have headache. So it's important to consider them together. Now, what is the impact of aerobic exercise and strength training on chronic headache? Well, we have to kind of pull from the headache literature. And in the headache literature, you have a lot of research on migraine and intention type headache. Those are very common headache phenotypes, so common types. And those are also present in headache after head trauma, with migraine typically being considered the most prevalent of the different types. And what the literature suggests is that performing aerobic exercise and strength training can impact headache days per month and intensity. And a recent study actually found that in individuals with persistent post-concussive symptoms, um, that aerobic exercise was able to decrease headache and depression and dizziness. So it may have an impact on other symptoms besides just the pain experience that occurs following head trauma. And one study that included chronic headache, in addition to other headache acuities in their research, found that uh, strength training and aerobic exercise reduced headache frequency during the month by about 3 days. And that's pretty substantial. If we think about that in context of a year, that's around 36 days a year that an individual gets back. That's in terms of bang for your buck. That's a good thing to hedge your bet on in terms of spending what you should spend your time on. And as I mentioned, these have been shown to improve pain intensity too. Now, the impact of aerobic exercise and strength training on chronic pain also shows that these are helpful for improving pain intensity and pain disability. And that if we consider them in terms of their efficacy um, related to each other, strength training seems to outperform aerobic exercise in improving intensity of the neck pain experience. And interestingly enough, when we combine the two, it seems to outperform strength training alone. So it suggests that what we should do is have a multimodal approach to the modalities that we use to treat um, pain after head trauma. And within a single modality like exercise, we should also diversify the types of exercise that we perform to access different pathways to ultimately improve sensitization that might occur. Okay, so kind of talking about starting an exercise program, it's important to, only start an exercise program once you've been cleared by a treating physician. And this is really important for individuals that have um, acute symptoms after head trauma, as the progression that an individual goes through is going to be different than someone who has chronic symptoms after head trauma. And so that's just kind of, once again, I'm highlighting these recommendations are for chronic pain after head trauma, as acute pain may need, a different type of oversight and recommendations that are more patient specific, because the nervous system may still be vulnerable to injury with exercise. Although I think it's really important to highlight that the current recommendations, they advocate, after the initial um, resting period, typically of like 48 hours, you really start to increase your activity to improve long-term outcomes and short-term outcomes after head trauma. So activity is really important. In terms of general recommendations for aerobic exercise, and these recommendations were actually pulled from a study that looked at chronic neck pain literature. So, kind of applies to what we're discussing today. Types of exercise can include cycling, brisk walking, aerobics, stationary bike, treadmill running, circuit training, swimming, just to name a few. Exercise intensity should be moderate to high intensity. The frequency should be 2 to 3 times per week. And the session duration should be between 30 to 45 minutes. Now, what is moderate to high intensity? We can use your perception of exertion to get a sense of what moderate to high intensity is. We can use what's called the Borg rating of perceived exertion scale. It goes between 6 and 20. And we have descriptors associated with different ratings. For instance, at the very beginning, no exertion at all. 11 is light, 13 somewhat hard. 15 hard, 17 very hard. So moderate is typically thought of as between 12 to 13, and high intensity is between 14 to 16. Now, for those of us who have a biometric equipment that is able to um, look at heart rate, we can use that to our advantage. First, we can get a general estimate of our maximum heart rate, which you can do with 220 minus your age. And then the moderate intensity is about 54 to 76% of that max heart rate. That's kind of the range you want to be within. And that what that looks like is you talking but not singing. For vigorous intensity, so more high intensity, this is kind of where you can only say a few words before pausing to breathe. This is around between 77 to 93% of max heart rate. Now, general recommendations for strength training, you're doing whole body resistance training and you're including neck and shoulder exercises. So, in terms of sets, we're talking about 2 to 3 sets. In terms of repetitions, 12 to 15 repetitions. In session duration, between 45 to 60 minutes. And for the progression, if you can perform 3 sets of 15 repetitions, then you increase the weight by 5% the next session. That's kind of the general recommendation. Now, in terms of things to pay attention to, um, we want to make sure that if any of these things occur while you're exercising, you do contact EMS, as they might be more indicative of systemic issues like cardiovascular issues that you want to have addressed. And I'm just going to read through these. It's chest pressure, tightness, squeezing, or burning, exercise-induced jaw, arm, or epigastric pain. That's kind of pain right above your belly, right below your ribs. Shortness of breath that is severe, worsening, or not improving with rest. Excessive fatigue not proportional to the activity. Blurred vision or double vision. Dizziness or lightheadedness. Loss of balance or coordination. Sudden weakness or numbness. Fainting or feeling like you will pass out. Confusion, disorientation, or altered mental status. Difficulty speaking or understanding speech. And severe exertion-related headache that's sudden or unusual. Now, these are some symptoms that you should be aware of and contact a medical professional, preferably one who's been treating you for your symptoms before continuing with the program if these non-painful persistent post-concussive symptoms return or increase at rest. And these could involve symptoms related to kind of the cognitive domain, so impaired concentration, memory, brain fog, sensation, so ringing in ears, nausea, light sensitivity, emotion, like elevated anger, frustration, depression, anxiety, persistent fatigue. And you want to reduce exercise intensity if starting pain increases greater than 3 out of 10, greater than or equal to 3 out of 10 during the exercise. So if you're doing the exercise and you start at a 2 and the discomfort increases to a 4, that's okay. If it increases to a 5, then that's where you consider reducing the intensity. And so that can look like for aerobic exercise, reducing your heart rate, reducing your rate of perceived exertion. For strength training, can be reducing the resistance load. And then if post-exercise pain is sharp and focal, so you can kind of point to it within a region that's been exercised. So say you're doing your shoulder and you can point to it, it's right there. It's really sharp and uncomfortable. Then you will probably want to reduce exercise intensity. And, it's important to note that generalized soreness is expected. So within an exercised area and acceptable if it, lasts in general less than 48 hours. Okay. And so now on to an intervention strategy for treating headache and neck pain after head injury using neuro reeducation and strength training. But before we do that, I am wondering if anyone has any questions. I know some of these slides were quite detailed, but they're for your reference, so you can come back to them at a future date and access them to consider your progressions. Any questions?
So you've been talking about headaches. Now, is there a difference in your opinion between migraines and the headaches that you're speaking of?
Yes. So that is a very good question. At this moment, what we know is the symptoms that an individual experiences are fairly similar. So the clinical presentation is pretty similar. But when we look, for instance, like at brain uh, activity, how different areas of the brain communicate with each other, we do see differences between migraine, non-traumatic migraine, and individuals that, for instance, have a migraine phenotype after head trauma. So I don't think we know exactly what that means clinically so much in terms of how they differ and how that impacts management. There are other things that, of course, dictate intervention strategies that are oftentimes unique to a head injury population, for instance, like post-traumatic stress to be addressed. But in terms of, you know, for the pain that's experienced, individuals that have similar presentations that are non-traumatic migraine and traumatic migraine, what intervention paradigm to use. At this point, we really don't have strong evidence for where they diverge, only that at this moment, the recommendation is to use the recommendations for non-traumatic migraine to support decisions for intervening on migraine after head trauma. Okay. I'm curious, and no need to speak up if you don't want to, but has anyone been suffering with chronic pain after their head injury?
Aaron, I don't know if you can see the chat, but someone
Oh
answered
yeah.
yes.
Okay, yes. Uh, and you don't have to describe your experience if you don't want to, but have you used exercise at all to try to manage your symptoms?
Yeah, I was at a point doing like stationary bike every day. And now my PT is like having me do more strength-based exercises now that like cardio is more okay.
Yeah, great. Great. Um, do you mind me asking what the the symptoms you were experiencing included?
Yeah, a lot of like head pressure for me specifically, tinnitus, and then the light and noise sensitivity and balance issues.
I'm curious, the aerobic exercise, did it help with any of the other issues, besides the pain? I'm sure you have other ongoing treatment that, you know, might make it difficult to say whether it helped or not. It's probably the multimodal experience that's helping, but
Yeah, but it's definitely like I notice I can walk farther than I used to be able to, which is nice.
yeah. And one thing that's interesting is exercise intolerance is a really big thing after head trauma. And an aerobic exercise plan has been shown to improve exercise intolerance after head trauma. So it's one of those things where there's a certain point where you have to realize, symptoms are likely not equaling damage. And, it's this sensitivity of the nervous system that needs to be addressed, and using exercise to address it can be helpful. Any chance you might want to talk about your experience? And no pressure if
Yeah, yeah, no problem. So I had my head injury as a result of a surfing accident, and I don't know if it was a board that hit my head or my head that hit the reef, but nonetheless, I ended up with a herniated disc in my neck also, and I end up, just periodically having like the pain waxes and wanes, kind of. So when there's less pain, I'm able to work out, I'm able to lift, I'm able to surf again. And then there's moments where something kind of triggers things. Like right now, I'm on like a 2 month where I have been doing kind of no physical activity, not even the elliptical, because my it's actually not on my neck. I got into a car accident. Now I've got pain radiating down my leg. And I'm wondering, seeing how the pain thing you were talking about, how it amplifies certain pain, if it really did injure my back worse, or am I just more sensitive to pain at this point? But it's keeping me from being able to do anything other than go to the gym. They have a recovery room and I sit in the massage chair and try to like find a little bit of a lead. I see a chiropractor, a physical therapist. I have an acupuncture appointment on Thursday, just trying to work through it and figure it out.
Yeah. Yeah, especially so, and that's one thing, if you've already had a sensitized state within the nervous system and then you experience something like whiplash that kind of can activate um, pathways that have already been sensitized a little bit more easy. So it has VIP access, maybe where you don't necessarily want it to have that access. But that's the case for a lot of injuries and sustaining an injury after a previous injury experience. And so the big thing is keeping doing what you're doing. It may take a little bit longer than the initial recovery route took, but it's important to keep with it. So yeah, it can be frustrating though. Okay, so let's go ahead and talk about pain amplification syndrome after your injury. Would you mind? Actually, I don't know um, pain amplification syndrome as a syndrome. Would you mind talking about what that is? Is it just like central sensitization?
Yeah, so the way it was explained to me, they kind of grouped it in the same family as like fibromyalgia type. So essentially what I was told is my body is taking like regular sensations and interpreting them as pain. So then the threshold anyway decreases and then everything causes pain.
Yeah.
I did go to a lot of like, physical therapy for it, where they would just take like different textures and have me touch it and then like slowly increase what that was. But yeah, essentially everything was painful for a very long time.
Is it still that way?
No, not really. So I think it can be, but it's not anywhere near what it was before. I still have some sensitivity to things, but now I know what they are and I can control it versus it's just everything all at once.
Yeah. What's really interesting is oftentimes like when touch becomes painful, just like non-noxious touch, the A beta fibers, which are response, I don't know if you hear my dogs in the background, sorry. The A beta fibers, this is getting into physiology, but I think it's really interesting, which normally transmit information like about pressure, for instance, gain access to the pathways associated with the pain experience. And their activation can kind of continue to perpetuate the sensitization within the central nervous system. I think what's really important to realize is that a lot of these, you know, experiences that you have with pain are really supported by physiologic events. It's not something happening in your head, that is a sign of weakness or anything like that. Because I've met a lot of people that think that, and I think modern society, unfortunately, has that narrative. But it's things that are out of your control that might be related to genetics and et cetera, that we can have some sort of control over, but there's a lot of things that underlie what we experience, and it's not our fault. And so we keep moving forward.
Okay, yeah, and unfortunately I had to step away for a moment, but when you were on the slide, it made me think you were talking about if you experience any symptoms while you're doing these exercises, like reduce the intensity or,
Mhm.
um, yeah, I think it was maybe this one. So, and it actually isn't related to headache, but I was doing cardiovascular exercise and I definitely felt the dizziness, the lightheadedness, and the fatigue. It was like the trifecta of those three. And I have to say, I guess what I was wondering, and if you want to wait till the Q&A part, you can. I just was wondering, do you have any experience or in the research even like how this secondary thing of kind of fear creeps in? Because
Yeah.
honestly, I have not gone back to that type of exercise and I want to, but I'm
Yeah.
kind of afraid to because it didn't
Yeah.
feel good. It was a little scary. And I was, at the end of it, I was sitting in my car thinking, oh, do I need to call someone? Do I need to, like how, just trying to really assess all the symptoms and then like, oh, okay. And and I learned some things, but I'm just saying that the fear was definitely activated along
Yes.
with those symptoms. Yeah, and I have not gone back to that. So I don't know if you can speak to any of that.
Yeah. So first things first, you always want, when you have symptoms like that, you want to make sure that it's, you know, not threatening
Right.
in the sense that it's something that needs to be addressed immediately. And so reaching out to a medical professional is definitely the way to go. It is really tricky after head trauma because like symptoms can present irregularly, in an atypical fashion as compared to individuals who don't have head trauma. And so that makes it scary and also is a reason for, embarking on an exercise program with some sort of health professional, being a part of that journey. So in the beginning, you don't necessarily get concerned by some of these phenomena that occur that, create fear. And rather, you can learn that, okay, this is normal for your experience, or this is something that you need to pay attention to and really have change your exercise experience. So I think it becomes increasingly difficult when we're working with headache after head trauma, or when we're working with symptoms after head trauma. It becomes increasingly difficult to, have a characteristic pattern of response that we can point to as being this is what, everyone's going to experience. People aren't going to, have an atypical experience. And it's just not that way, increasingly so with headache or with head injury survivors. So, and with fear being a big part of, why we do what we do, um, having, like I said, someone along for that journey that's able to uh, essentially diagnose out whether this is an issue or not can be really helpful in making sure that you're continuing to do the things that will benefit you.
Yeah. Yeah. And thanks for that. And I think in my case, I think that I think it was really a matter of me pushing it. Like in part of that's kind of generally this whole experience, kind
Yeah,
of pushing it. It's almost like you don't know you're gonna, because you don't know you're experiencing these things. And so then you've overdone it pretty quickly.
yeah,
Um, and so I think it was that case, but like I said, I'm not really excited to go back and try that.
yeah.
Um,
Well,
but finding a cardiovascular, finding exercise you like that works with your schedule, that's good. I mean, we just want all these, I want those things, right? To make it more likely to me to do it, whether it be kind of convenient to do or that I like to do that in the first place type of thing.
yeah. And you can schedule like a stress test, right? Where you're pushing yourself cardiovascularly and you have medical professionals that are monitoring.
Yeah.
And that would
Yeah.
be, if you're experiencing those symptoms, I would say, yeah, that would be a good first step. Because it might just be, that's a byproduct of your system being sensitized. And it's something that will reduce in sensitivity, but you just want to make sure that it's not something else.
Mm.
So, um, and fear is just such an important thing to consider when you're thinking about, you know, engaging in any sort of conservative treatment strategy. It is a barrier towards to recovery for so many conditions, chronic pain especially, and we have a lot of evidence to support how fear reduces the ability to improve. And and for a number of different reasons. So that can be another reason, like you use other strategies like cognitive behavioral therapy or, psychotherapy to help work through that to improve your experience with whatever's causing you fear. And then even like if you're going to a physical therapist, for instance, then um, it's about getting used to the activity in an incremental fashion, right? So ultimately, over time, you don't have that fear barrier during those different steps, and you ultimately get to where you want to reach without the fear experience along the way, because
Hmm.
you're not trying to overcome a hurdle that is too large and too fear provoking. So,
Okay. Thank you.
yeah. All right. So the exercises, right? Um, a lot of times people do exercises. Uh, oh, vestibular nightmare, working back up to it. Yeah. The vestibular system is a big reason for uh, like exercise intolerance. And so addressing the vestibular system in conjunction with everything else is important. I mean, multimodal, right? That's really the theme for recovery. Okay, so exercise, right? The exercises that I'm going to demonstrate are going to be done in my bedroom, and that's consistent with how a lot of people do their physical therapy exercises. So please don't mind the room. But we're going to talk about some exercises that can be used for head and neck pain after head injury. So I'll go ahead and move through these exercises. You'll have access to this video to go ahead and reference them. I was going to have people kind of participate along, but I think it might be we're already kind of approaching 6:30. So I know if you have to go, um, the please do so. There will be a video kind of explaining exactly how to do the exercises. And if you do the exercises and if you have any questions, please don't hesitate to reach out. So an active warm up is a great place to start, right? And here are a number of movements that you can move through for that warm up, moving through the neck, moving through your shoulders. And so, for instance, you're going through cervical flexion, you're bringing your chin down towards your chest. You want to go through your full available range of motion. You should feel some tension across the tissue that's being stretched. And once you get to that point, you want to have a 1 second hold and come off of it. You don't want to have an increase in pain during this experience. It's supposed to just be a warm up. So we have the cervical flexion where you're bringing your chin towards your chest. You're feeling a little bit of a stretch in the back of your neck, and you hold it for for 1 second, and then you come back up. So it's a 1, 2, 3 down. Feel that tension slightly develop, hold for one, and then come back up. And you're doing 3 repetitions. And then you go into cervical extension, where you're rolling through your neck all the way towards looking at the ceiling. You hold for 1 second and then you come back down. Once again, it's a 1, 2, 3, hold, and then you come back down to baseline position. You're doing 3 times. And then rotation. So you want to be nice and upright. You can do this in a seated position and standing, and you want to rotate. You can start by going to the right, go to the point where you start to feel tension on the left. You may even feel some tension on the right, and you hold for 1 second and you come back. And then you can go the opposite direction. You're going to go 3 times each way. Motion is lotion, and movement is key for reducing sensitivity. So, these essentially are the beginning of the exercise intervention. They are just as valuable as the other exercises, at least initially, when you're trying to kind of desensitize the system. So once again, it's a 1, 2, 3. Hold for 1 second. 4, 5, 6. And you're doing 3 times each way. And now you go side bending. So you're nice up and right. You're going to bring your ear towards your shoulder. You're not going to rotate down, so your nose is not going to go to your shoulder, but rather your ear. Your nose is going to face straight ahead. And you'll go 1, 2, 3, hold for a second, 4, 5, 6. And then you'll go the opposite direction, 1, 2, 3, hold for a second, 4, 5, 6. And so when you're going to the right, you should start to feel some tension on the left. It's okay if you feel some on the right. That is oftentimes um, a symptom that people experience with chronic neck pain, but you're going to go 3 times each direction. And then you move to your shoulders. So you'll go ahead and raise your arms up just like this. And you'll hold for 1 second, and then you'll bring it back down. So it's a 3 second rise. 1, 2, 3, and hold, and then back down. Slow and controlled is the name of the game. And then extension, what that will look like, you'll go ahead and bring your arms back. 1, 2, 3, and then forward, and then back. 1, 2, 3. Hold for a second and then come back. You should feel a little bit of a stretch in front of the shoulders. And, for some individuals, this warm-up routine might be enough before you start on with the other exercises, and that's okay. It all depends on the sensitivity of your system. The most important thing is that you are starting to move, you're starting to take the first step to increasing activity, which has been shown to be helpful in reducing the pain experience. And the next exercise, warm up, is internal rotation. So behind you, 1, 2, 3, up your spine, like so, and then back down, and then up. 1, 2, 3, hold, down, and you're doing it on both sides. So 3 times on both sides. And then the next one is rotation. So this is kind of like a football touchdown sign. It's football season right now. So you're coming up and then back down. And it's a 1, 2, 3, up, hold for 1 second, and then come back down. Very simple. Some of you, this might be enough. Some of you, this might be too easy, and that's totally fine. You can quickly move through it. You can use another warm up if this is too easy. For instance, like a short walk or short jog if you've progressed to that. Okay, so for the first exercise set, it's really about setting the shoulders, setting the upper trunk. We think of our neck and our head as built off of this upper trunk area, right? So in this upper trunk area, the stability that it provides for our neck and our head to move really comes through a number of different muscle regions, one being the muscles that come from the back to the shoulder blades into the shoulder. So having a good foundation for the upper trunk region is really important for how the muscle functions in the cervical spine and that tissue that goes into the head. So we call this robbers or set the scapula. So you can have your hands like this. It wasn't me. Okay. And what you do, you're going to have you're going to imagine there's a bungee cord between your shoulder blade and the opposite back pocket. And so my right shoulder blade in my left back pocket, my left shoulder blade in my right back pocket. And what I'm going to do is I'm going to pull my shoulders down and back in a diagonal. I don't know if you can see it, diagonal. So it's coming down and back towards my opposite back pocket. And I'm holding it there for 3 seconds and I'm relaxing. And then I bring it down and back. I hold it there for 3 seconds and I'm relaxing. And this isn't you're going all the way and pushing your chest out. That's not very functional. It's a bring your shoulder blades down and back, hold for 3 seconds, and then relax. Oftentimes with neck pain and headache, how our muscles coordinate their activity together becomes impaired. And so this motion, even though it seems simple, can be difficult to perform. And what you might find is that your shoulders start migrating up towards your ears. You might find coming down and back becomes difficult, and you have really kind of jerky movements. And so those are just things that you'll work through as the nerve is really improving its communication with the muscle. Your movements will become more smooth and more fluid in the pattern of movement that you want to see. And so after you've done this exercise for a week, because it's important to kind of facilitate that nerve to muscle connection so it's ready to handle more strenuous exercises, and it isn't provoking any of your symptoms. It's easy to perform all 3 sets of 15, and you're able to hold for 3 seconds. Then you can go ahead and move on to the rows against resistance. And of course, your movement is good and you're not bringing your shoulders up towards your ears. And so the rows, what you can use is you can just use like a TheraBand, so a band like so, and you can tie a knot in the middle. So, and what you can do, and I'm going to bring you with me to the door. So what you can do is just trap that knot right in the door frame itself. This is if you don't have access to like exercise equipment where you would have weights. And so what you'll do is you'll first bring your shoulder blades back like you were doing with the scap set, so down and back, and then you will pull, bringing your elbows in line with your side pockets. And you'll hold for 3 seconds, and then you'll relax. So return, and then you'll bring your shoulder blades back, and then bring your elbows so they're in line with your side pockets. You'll hold for 3 seconds, and then you'll return. And so that's how that exercise looks. You want to try to keep nice and relaxed in the neck region. That's really important because you do not want to have those muscles within the neck really tensing up as you are going through the exercise. The next exercise to perform is cervical extension. And so what this looks like, this can be performed, for instance, on your bed, which I'm going to do it on. Here we go. Okay, so you're on all fours, just like so. If you can't be on all fours, I'll give you an alternative position. But what you want to do is you want to have your head in line with your trunk, just like so. So nice and straight. Your hands underneath your shoulders, your knees underneath your hips. And you're going to first imagine something pointy at your chest, and that you have to move away from that pointy object by pushing your chest up towards the ceiling. And so your shoulders will kind of round around your upper trunk. They're not going up towards your ears, but round around your upper trunk, bringing your chest up and away from the bed. And your head straight and in line with your trunk. And then what you do is you have your chin gently tucked and you lift your head, you hold for 3 seconds, and then you return. And then you lift your head and hold for 3 seconds and return. And you're fulcruming through the bottom, the base of your neck. So, and you don't want your chin to jut out as you're doing it. Your chin stays tucked as you lift, so you're not doing this, and you're holding, and you're doing 3 sets of 15 where you're doing a 3-second hold at the top. Once that becomes easy, what you'll do is you'll add, for instance, with like these bands right here, the rope TheraBands aren't going to work very well because they'll roll off the top of your head. But what you'll do is you'll have a band around. So you'll get into that position. You'll create some tension through the band. And so you bring your chest up and away. And then what you'll do is you'll lift the head up. So I'll bring this up just a little bit, take my glasses off. So shoulders, my chest up and away from the bed, my chin tucked, and my neck straight. And then I'm keeping my chin tucked and then lift up. And now I have resistance that I'm encountering. And back down and up and resistance that I'm encountering. This is not the best band. These larger surface areas, so larger width, larger surface area is going to be a better bet for uh, for this exercise. But as this one is kind of rolling off too. So here, in line, and then lift up, hold, and back down, making sure that your shoulders aren't migrating up towards your ears. So that's cervical extension. And then scapular protraction, you can just do this with 1 pound weights, which are essentially soup cans. All right, I got 2 bean cans right here, and you're on your back like so. And you have your arms straight, and the cans are up towards, there we go, towards the ceiling, just like so. And what you'll do is you'll punch towards the ceiling by bringing your shoulder blades out and around your upper thoracic cavity, so your upper body's cavity, and so your upper chest, and you'll hold for 3 seconds and then relax. And then you'll push up towards the ceiling, keeping a little bit of a bend through your elbow. Push and then relax. So up towards the ceiling, your shoulder blades go. You hold for 3 seconds and then you relax. And again, up towards the ceiling, hold for 3 seconds and then relax. And once you're able to do that, then you can move on to this exercise in sitting, where you have a band behind you. You're doing the same thing, except now you are not laying on your back. You're upright in a seated position, or you can do this in standing, and you're holding the band like so, and you're pulling your shoulder blades out and around, wrapping it around your upper rib cage, holding for 3 seconds, and then relax. And once again, out and around that upper rib cage, hold for 3 seconds and relax. And out and around that upper rib cage, hold for 3 seconds and relax. And it's a challenging exercise, and it's a useful exercise for activating what's called your serratus anterior, which really helps to stabilize the shoulder blades, which is really important for the stability of the head and neck. And then the last one pertains to cervical flexion. And so what this looks like is you're going to take a towel roll. I'm going to use my daughter's burp cloth. And this will go behind your neck, just like so. So it sits within the curvature of your spine, your neck. You can have your knees bent so your back stays relatively flat. You can have your hands on your chest. And what you're going to do is you're going to tuck your chin, increasing pressure against the towel roll that's behind your neck. And this is a little bit different than the other exercises, as you're holding for 10 seconds and you're doing it 10 times. So you hold, 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 and you relax. You don't want to you don't want to push your head back and have your chin jut like this. You want to keep your chin tucked as you're pushing back. And really, you want to create that pressure by tucking your chin instead of really using muscles at the top of your skull to push your head down into whatever surface you're lying on. So chin tuck, increase the pressure, hold for 10 seconds, pushing into that towel, and you relax. You do that 10 times. And once you're able to do that, and initially you'll probably feel pretty shaky and it will be pretty fatiguing. Once you've done that, then you're going to go ahead and start with the chin tuck and then do a gentle lift. And you're going to hold. And you can do 3-second hold and then relax, come back down, gentle chin tuck and lift. So 1, 2, 3, back down. And you'll do 3 sets of 15. Once this becomes easy, you can add some weights, like ankle weights on your forehead and make it a little bit more difficult. That's one way you can go about it. Another thing to think of is oftentimes when you're doing this, your shoulder blades might want to migrate up towards your ears. Set the right foundation by bringing them down and back. Tuck your chin, lift. So have the upper chest nice and stabilized. It'll make it easier to activate these muscles here when the upper body has the appropriate amount of stability. All right, so those are some different exercises that you can use for trying to improve headache and neck pain. Um, Please let me know if you have any questions, concerns, or hateful remarks.
Thank
I
you.
have a question.
Yes.
Erin, do you find that either before or after let's say the mechanism of injury, be it a car accident or a blow to the head, that those patients have a weakness in either neck flexors or extensors before the injury or after? I understand if you're in a car accident, it's almost, it's going to be, if it's a pretty rough one, it may make no difference at that point.
Yeah.
But before and after, do you find there weakness in one, the flexors over the extensors, or vice versa?
Yeah. So essentially, what you're asking about is like a prospective trial that looks at neck flexor and extensor strength before any sort of injury and then what it looks like after, right? And the research that I know a little bit about is like veterans who are in high risk situations and then also football players. Um, I think I don't know this research very well, but I think there is some evidence to suggest that weaker neck muscles do increase the risk of like a head injury. So actually, I think that has been established for instance, like contact sports.
Mhm.
But it's not literature that I can tell you
And
off.
what flexors more than or weaker more than extensors or
Yeah, so that's a good question in terms of which matters more. Um, mm, I don't know, and I imagine it would both can both could potentially have a role to play. There's an argument for a mechanism that both could there's argument for a mechanistic pathway that both could have towards increasing the risk, and I don't know of literature that implicates one over the other.
okay. Thank you.
But I do know that after, head injury or sorry, after neck injury, for instance, yeah, the neck flexor strength tends to change. And what seems to be one of the biggest changes is the coordinated activity of these muscles with one another.
Mhm.
So hence the neuro reeducation part, like the stuff you do before you start a strengthening program, kind of those level A exercises can be helpful and important so that when you do something more strenuous, you're activating the muscles in the right way.
Thank you.
Yeah.
I think we're all gonna take these and start our exercises tomorrow morning. I know I am.
Mhm.
I
Yeah. Thank you, Erin.
Yeah,
Thanks, Erin.
I just so you know, I love if you do and you're having questions, this is such a small group. don't hesitate to reach out. That's I can easily help with that.
Thank
I will
you.
s- I will say like when people start head and neck exercises after they've had like chronic headache and neck pain, it's very common to have residual pain occur after your sessions. And so, you know,
Mm.
it is okay to really take it easy initially and progress from like a good baseline starting point where you're not having pain with your experience, reduce that fear. So you continue with the exercise because the last thing you want to do is discourage yourself. And if you need tips and tricks for how to alter the exercises, I'm more than happy to help with that.
Thank you. That's great that you mentioned because it will probably happen to me and I would have stopped. So good
Yeah.
to know. Thank you so much. We started a bit late, so we ran a little over. But if anyone has any questions, let us know now. Okay. It sounds like no one does. You were great. Thank you so much for your time, Erin. We
Yeah,
appreciate
thank
it.
you.
We learned a lot and we should get to work and we'll get back to you if we have any questions. Thank you so much. Hope everyone has a great evening.
Yeah, and just really quickly, so February 10th will be the next uh yeah, the next session. And we have the workshop series scheduled out till November, so we're doing good. We just have
Wow.
a couple more or till October, so we just I think have November and December to fill up. So we're going good.
Nice. Yeah, that's great. Thank you.
Yeah. Thank you everyone for your attention and
Thank you.
contributions, questions, all of that.
Good night.
Thank you.
Bye.